I'm Dr. David Samra, Medical Director of Progressive Longevity and Clinical Lecturer at the University of Sydney. I'm a sport and exercise medicine physician with a long-standing focus on musculoskeletal health, metabolic disease, and performance medicine. What we've built here at Progressive Longevity is a specialist-led, evidence-based longevity clinic that moves beyond reactive medicine and into prevention and performance. Our goal of testing is very simple: to identify disease early and risk early, to quantify physiological reserve, and to guide targeted, personalised interventions across metabolic, cardiac health, body composition, fitness, and musculoskeletal integrity. Rather than screening broadly and making assumptions, we use highly targeted, high-resolution biochemical, functional, and structural testing to understand how patients process energy, how their cardiovascular and metabolic systems are performing, and how their body composition and musculoskeletal system are adapting over time. Everything we measure here is designed to be actionable, something that directly changes clinical decision-making, lifestyle prescription, or longitudinal risk management. Phase 1 of our longevity program is our intensive diagnostic phase. It's conducted over the first 4 to 6 weeks. This is where we build a complete objective risk and performance profile for each patient. It begins with a specialist medical consultation where we take a comprehensive history which is focused on cardiometabolic risk, family history, prior injury and pain, sleep, stress and behaviour, and performance or aging-related goals. This is all grounded in a Medicine 3.0 framework: proactive, longitudinal and prevention-focused. From there, we move into biochemical testing, which forms the foundation of our metabolic and vascular risk assessment. This includes full metabolic and lipid profiling, insulin sensitivity and glycemic control, advanced lipid markers such as ApoB and Lp(a), inflammatory markers, micronutrients, and selected hormonal panels where appropriate. These results allow us to move beyond traditional normal ranges and into true risk-stratified prevention, particularly for atherosclerotic disease, diabetes, and neurovascular disease. At the same time, many patients undertake CGM or continuous glucose monitoring for 2 to 4 weeks. This gives the dietitian the ability to give you individualized advice based on your specific individual patterns and response to different fuels and foods and your own metabolic flexibility. This data is far more powerful than a single fasting blood test and directly informs nutrition, sleep, and exercise prescription. We then integrate this with functional and structural testing, including aerobic capacity, metabolic efficiency testing, and high-resolution body comp assessment, including visceral fat and lean mass distribution on DEXA. These measures all tell us how well a patient's cardiometabolic system's functioning, how they're partitioning energy, and how much true functional tissue reserve and capacity they have as they age. Finally, our exercise physiologist assessment translates all of this into identification of functional deficits and asymmetries, aerobic and anaerobic capacity profiling, VO₂-based training zones, and structured strength and conditioning frameworks. What's critical here is that none of these elements exist in isolation. Every blood marker, CGM tracing, VO₂ metric, and DEXA variable feeds into a single integrated model. At the 6-week mark, we then consolidate everything into a specialist review, where we define personalised risk targets, medical and lifestyle strategies, and a long-term prevention and performance roadmap. This is how we ensure that our testing isn't just comprehensive, but it's clinically meaningful and outcome-driven. What we're really looking at here is not a collection of numbers. It's a dynamic snapshot of how the body's functioning at a cellular and systems level. Every blood marker tells us something about how efficiently the body is producing energy, repairing tissue, handling inflammation, and managing long-term disease risk. So rather than just asking, is this within the normal population bell curve range, we ask a much more important question. Is this optimal for this individual, their age, goals, and long-term health span? So these results allow us to detect early metabolic strain, silent cardiovascular risk, micronutrient inefficiency or deficiency, hormonal dysregulation, and inflammatory load, often years before disease becomes clinically apparent. So blood testing in our model isn't just a shopping list It's the biochemical blueprint that guides precision, prevention, performance optimization, and long-term resilience. One of the most important reasons we do early blood testing is that insulin resistance develops silently for years before glucose ever becomes abnormal. And patients can sit in this so-called normal glucose range while their insulin levels are skyrocketing and their metabolic signaling is massively impaired. At this stage, the pancreas is simply overproducing insulin to keep the glucose levels normal. And this is what we call compensated hyperinsulinemia. Clinically, this is where we see rising fasting insulin, worsening lipid ratios, rising visceral fat. This is on the way on the spectrum of type 2 diabetes. The greatest return on investment here is to optimize all of the lifestyle factors: nutrition, sleep, exercise, and mental health. And what we want to do here is detect it early when the condition is still so highly reversible. Now, outside a formal insulin clamp done in a research lab, this is the best real-world way we have of objectively quantifying insulin resistance by directly measuring the magnitude and the duration of the insulin response after a glucose load. What matters clinically is not just whether the glucose returns to normal, but how hard the pancreas has had to work to achieve that. Now, a small brief blip in insulin is good sensitivity and represents good resilience, but a large, prolonged rise and delayed downstroke says the system is already under strain. The higher and more prolonged the response, the greater the future risk of type 2 diabetes, cardiovascular disease, fatty liver, and even cognitive decline, even when fasting glucose and A1C still look acceptable. So just importantly, this tells us about reversibility. Earlier patterns are highly reversible with targeted exercise, nutrition, sleep, and weight-independent improvements in insulin sensitivity. But more advanced patterns require longer and more intensive intervention. So this test, the CRAFT test, allows us to move from a vague risk estimate to precise stratification and disease trajectory and the response potential. Now, atherosclerosis is not an event. It's a slow, cumulative biological process that progresses silently over decades if the conditions allow. And this is what makes it so hard to understand and quantify. What we're trying to understand here with our testing is not just a cholesterol number, but the true drivers of plaque formation and artery aging. ApoB tells us the actual number of potentially atherogenic particles interacting with blood vessel walls. In other words, how much traffic is passing through that artery wall that can form plaque. Another test, Lp(a), tells us more specifically if there's a genetic risk here. In those higher risk patients, we can also measure more advanced lipid markers that indicate whether they absorb or synthesize too much cholesterol, and in other cases, whether they have small dense LDL harmful particles. By measuring these things early, we can define vascular risk with much greater precision and, more importantly, modify the biological environment that allows that plaque to accumulate through targeted exercise, nutrition, metabolic optimization, and where appropriate, medication therapy. Atherosclerosis is still the #1 killer in our society. The cardiology colleagues of mine know this all too well, and once patients have a major adverse cardiac event, their quality of life often never recovers. So this process is about slowing the rate of artery plaque formation now, long before symptoms and events ever occur. Hormones don't act in isolation. They're part of an integrated adaptive signaling network that governs how we respond to stress and training, how we regulate mood, maintain metabolic rate, and remodel aged or damaged tissue over time. When we assess these hormones in our clinic, our objective is not replacement or enhancement. We're specifically interested in understanding why the system is in strain or it's out of rhythm, whether that's driven by impaired sleep, recovery, stress, or energy imbalance, or metabolic dysfunction. Cortisol, thyroid, key anabolic signals as well, they all give us insight into recovery capacity and the system load. And in many patients, what looks like a hormone problem is actually a behavioural physiological mismatch. So too much stress, too little recovery, and inadequate metabolic support. Our goal is always to restore hormones in synchrony naturally through an active lifestyle-based optimization program so the body can adapt and thrive without the dependency on exogenous hormones. But if after true optimization there is a clear pathological deficiency, that becomes a medical conversation and likely an endocrinology review is in order. But our clinic is firmly grounded in lifestyle-first, physiology. When we look at micronutrients now, we're not just screening for outright deficiency, we're specifically looking for suboptimal levels that quietly limit energy production and recovery, immune function and tissue repair. Iron, B12, folate, magnesium, vitamin D, and zinc all act as biochemical switches inside the mitochondria of our cells, and even when normal values fall within a lab normal range, being below an individual's optimal range can massively blunt training adaptation, slow down recovery, impair cognition, and increase fatigue and impair sleep. So our goal isn't to recommend supplements indiscriminately, it's to fine-tune the cellular environment in the body so that you can actually express the full adaptive and regenerative capacity that the body is so good at. Low-grade chronic inflammation is one of the main biological accelerators of aging and disease, and it's often silent for years before symptoms begin. By measuring targeted inflammatory and immune markers, we can detect immune activation, oxidative stress, and dysregulated repair long before tissue damage occurs. Tracking these markers over time allows us to adjust training load, nutrition and sleep, and recovery so the body remains in an adaptive state rather than the chronically inflamed one. Our genetic testing is highly targeted and purely diagnostic. We don't use broad DNA screening tests. They've got limited validation. In selected patients, we look at a small number of clinically meaningful variants like ApoE, HFE, MTHFR to understand inherited differences in lipid handling, iron metabolism, and methylation, respectively. Our genes outline predisposition, but they don't determine our destiny. They simply give us an individualized risk management and prevention approach with greater precision. In select individuals, we also assess biochemical markers of bone turnover to understand the balance between formation and resorption. This is particularly important in patients with low energy availability, hormone disruption, high training loads, or age-related risk. And these markers help identify early bone stress and impaired adaptation well before changes occur on imaging, allowing us to intervene early, often with the help of our endocrinologist colleagues, to preserve long-term skeletal integrity. As for the gut, we focus on targeted evidence-based markers of true pathology where needed, such as H. pylori and fecal calprotectin. And these are to identify infection and clinically meaningful inflammation that can affect immunity, metabolism, and nutrient absorption. While we appreciate the evolving science, we deliberately avoid broad, unvalidated microbiome testing because it doesn't reliably change management. Environmental and heavy metal screening is also selectively and indication-driven. We only test when there is a credible exposure risk or clinical signal using validated assays with the goal of detecting genuine toxic burden. The principle in both areas is the same: test where results are meaningful and actionable. So alongside this biochemical testing, we also perform on-site structural assessment with exercise physiologist Cameron Hyde using our in-house DEXA scanner. This gives us an objective, gold standard measure of bone density, visceral fat, and lean mass. It allows us to anchor the blood results to true tissue level structure and to understand mechanical resilience. A whole body scan can take less than 10 minutes and give us detailed information. In select individuals, a formal bone density scan can then also be performed on the same machine. Finally, we add functional testing with VO₂ max and strength assessments to qualify how the body actually produces and applies energy in the real world. This translates the blood and the structural data into true physiological capacity and resilience. It allows us to track whether interventions are genuinely improving performance and long-term health. And it's important to note that with medical oversight and direct supervision, a VO₂ max test, which frankly for some people is quite an intimidating concept, can be performed on most people, even using submaximal protocols and different exercise modes to maximize tolerance and safety. All of this data only matters if patients can actually see it, understand it, and act on it. And that's where our progressive longevity app comes in. It brings everything together into a single live dashboard, translating complex testing into simple, summarized outcomes. In this live dashboard, patients can track what matters most over time. Alongside this, each patient receives a personalized action plan and targeted educational resources that align with their specific risk profile and goals. The aim here is simple: to keep patients informed, engaged, and in control of their long-term health journey, not just reviewed once and forgotten. At the end of the day, Medicine 3.0 is about having access to biochemical, structural, and functional tests that help drive earlier, more informed, and consistent health decisions. And these decisions, if performed earlier, have time to compound in their benefit. The purpose of everything you've seen today is to provide an understanding of our processes that we use to give patients clarity, direction, and confidence in how they look after their health. This content is provided for general educational purposes only. It is not medical advice, does not replace consultation with a patient's own doctor, and should not be used to make individual health decisions. Nothing in this presentation is intended to bypass or replace the role of general practitioners, oncologists, or established screening programs. No patient-doctor relationship is created by viewing this content. If a patient has symptoms or concerns or abnormal results, they should seek prompt assessment from their GP or treating specialist.